Welcome to The Explainer. Today, we're jumping right into a topic that's really shaking up cardiovascular risk assessment, lipoprotein A, or, LPA. And for you endocrinologists out there, understanding how to evaluate this isn't just a nice to know anymore, it's becoming absolutely essential.
So let me start with a question for you. What if a major, causal, and super common cardiovascular risk factor was just hiding in plain sight in your patient population? And this isn't some abstract thought experiment. For a lot of us, this is the clinical reality of LPA.
The scale of this is frankly kind of startling. We have consensus statements from huge groups like the European Atherosclerosis Society estimating that 1 in 4 people, 1 in 4 worldwide, has an elevated LPA. This is not some rare bird. It's a massive public health issue that's walking into our clinics every single day.
And the science, it's not really up for debate anymore. The 2024 National Lipid Association update couldn't be clearer, calling LPA, and I'm quoting here, important independent causal risk factor. Let's just hang on that word for a second. Causal. That's a huge shift. It moves LPA from just being a marker that's near the scene of the crime to being a direct driver of the disease itself.
So why the intense focus on LPA all of a sudden? It's because we are right in the middle of a massive paradigm shift. There's a whole new wave of evidence that has completely flipped how we need to think about this lipoprotein.
For years, we kind of treated LPA risk like a light switch. It was on or off. You were either high risk or you weren't, based on some single number. But these huge studies, like the UK Biobank analysis, have totally torpedoed that idea. We now know the risk isn't a switch, it's a dimmer. It's continuous and log linear. The higher the LPA, the higher the risk. Period. There's no magical safe zone.
And this is so significant. The latest NLA update actually points out that increased ASCVD risk is now being seen even at levels we used to think were low risk, down in that 25 to 50 nanomoles per liter range. So the big takeaway, a much, much larger slice of our patient pie carries this LPA-driven risk than we ever realized.
Okay, so how do we take all this science and actually use it in the clinic? Well, it boils down to a pretty simple 3-step framework: screen, measure, and stratify.
Step 1. The most basic question of all. Who are we supposed to be testing for elevated LPA? The good news is the answer has gotten a lot clearer recently. The recommendation from both the NLA and the EAS is now super simple and direct. Measure LPA levels at least once in every single adult. Just once. Since the levels are genetically set for life, one test is all you need to inform their risk forever. That's a pretty clear call for universal screening. Okay, so once we decide to test, the next logical question is how to measure it the right way. And this is where a few lab details really matter.
You're going to see LPA reported in one of 2 units. The one that the guidelines prefer is nanomoles per liter, or nmoles/L. That's because it reflects the actual number of particles. The other common one, milligrams per deciliter, just measures weight. And since LPA particles can vary in size, counting them with nmoles/L gives you a way more accurate picture of the risk.
Now here is a critical all-caps warning right from the guidelines. Do not, I repeat, do not try to convert between these 2 units with some fixed conversion factor. It's just not accurate. Doing it can lead you to seriously underestimate a patient's risk, and that can lead to undertreatment. So please always interpret the value in the units the lab gives you.
All right, and finally, the most important step of all, you get the lab value back. What do you do with it? How do you turn that number into a real clinical risk category for your patient?
The NLA has actually given us a really straightforward 3-tiered system. You've got low risk, under 75 nanomoles per liter. High risk is 125 or greater, and then there's that intermediate zone in between. This gives us a really practical way to stratify our patients and decide what to do next.
So now we've got the number, we've got the risk category. Let's talk about putting it into action. How do we actually incorporate this into a patient's overall management plan?
The best way to think about an elevated LPA is as a risk-enhancing factor. It doesn't live in a bubble. It's a risk multiplier.
It takes a patient's baseline risk, the one you figure out with the standard calculators, and it just cranks up the volume.
And here's what that can look like. A patient you might have pegged as moderate risk based on everything else, well, their high LPA level could easily push them into the high-risk category. And that reclassification, that's your trigger. That's your signal to manage all their other modifiable risk factors way more aggressively.
Now here's a little twist in the story that's especially relevant for you endocrinologists. The EAS consensus statement brought up this really interesting and maybe a little counterintuitive connection. It looks like lifelong very low LPA levels might be linked to an increased risk of type 2 diabetes. The why is still being worked out, but it's a crucial piece of the puzzle to keep on your radar.
So finally, let's look ahead. The whole world of LP management is on the verge of some dramatic changes, and that's exactly why identifying these high-risk patients has become so urgent right now. And this urgency is all because of what's coming down the pipeline. We have these incredibly potent, specific LPA-lowering therapies that are already in late-stage trials. We're talking about agents like pelacarsen and olpasiran that are posting reductions of 80%, up to nearly 100%. The big cardiovascular outcome trials are ongoing, and we expect that data soon.
But we don't have to wait for those trial results to do something. The action plan for today is crystal clear, and it's backed by all the major guidelines. Finding an elevated LPA in a patient is your signal to get much more aggressive with everything else you can control, and I'm talking especially about LDL cholesterol and blood pressure.
Which brings us to a final question, something to think about for your own practice. With specific, powerful treatments right around the corner, the time to start finding these patients is now. So, are you finding that 1 in 4 patient whose whole cardiovascular story is being driven by their LPA level? Because identifying them today is how we get them ready for the therapies of tomorrow.